Real briefly, before we get started, there's been a lot of talk about getting back to normal and what is normal. I think you've heard through the past couple of months through these briefings that when we get widespread testing and rapid testing, we'll kind of go into a new normal. And when there's an effective vaccine, that's when maybe we can get back to our old normal. That's why we have Christy back here. It's been an important week for Bryan in completing our in-house lab capabilities that we've shared with you in the past. And it's going to be, I think, even more important because as of today, we've tested 1,711 patients here at Bryan. I know some of them would have been out of county as well, but Lancaster County itself has only tested 1,844. So Christy's team building this additional capability is going to be so importantly as we move forward, no matter how long our new normal lasts. So she's going to do a little show and tell for us. And for the media, we will also be sending out some B-roll of our lab, actually, what they built and how they are conducting those tests. So let's get right to the numbers. Our midnight census was 369 last night. Our screening visits through Easy Visit are now at 9,563. Our total Easy Visits completed through that are 2,796, resulting in 1,288 people using the COVID promo code. Overall, I did just mention, but we have now tested 1,711 people at Bryan. 76, unfortunately, are positive, 1,523, fortunately, negative, and we have 112 pending in-house. So with that, I'm going to ask John to come up and share some information.
Thanks, Bob. I'm John Woodrich, CEO of Bryan Medical Center. So to talk about those numbers, we actually had 87 people come through our drive-through yesterday. As you recall, we upped that to 110 potential. We have 7 COVID positive patients in-house, and we have 5 that are still pending results. Of the 7 in-house, 4 are from Lancaster County, 3 are from outside of the county. Of the pending, 3 Lancaster County, 2 outside of the county. We have 4 people on vents, 7 individuals in the ICU, 1 in PCU, and 4 in general care. With that, I'm going to turn it over to Christina Nickel.
Hi, I'm Christina Nickel. I'm the laboratory director here at Bryan, and I'm here to talk a little bit about what the testing we do in-house involves. Our laboratory has a great staff that have worked really hard to get this brought up in our laboratory. This is something that we've never done before. We've brought in our own tests, so it's been exciting to see them work through that. I've got today one of our cassettes that we actually use for testing. This is for a different assay because it already has this little piece on here. This is where we add the primers and probes that you've heard us talk about having difficulty getting. We apply that, and then this actually snaps into the cassette. We apply our sample and close that and put that into our analyzer. This all has to be done in an enclosed system that's really carefully monitored so that we don't have any cross-contamination. And then this closed device actually goes into our analyzer. It sounds pretty simple, but it's all of the probes and primers and all of the other pieces that we've had to create that have made this a special process for us with emergency use authorization from the FDA. Once we get that completed, we are currently running about 5 to 6 samples a day based on the samples that we are getting in-house. We're limiting this to our inpatients and healthcare workers today. I say today because every day is a new day, and we look at when we're going to be getting supplies and make that decision every day. Today we'll be doing the employees and the patients that are in-house. We have 5 samples, I believe, pending that we'll be running today, and then probably a few more from the drive-through today. Once that gets placed onto our analyzer, it takes about 2.5 hours to run through a cycle. When we get those results, we enter those manually. Currently, we're working on our interface, so it'll automatically go through. The specimen we're using is nasal pharyngeal swab. We can run our test on the viral transport media. We can use saline, or we can go direct from the swab. We are using this in a good way. It does still require some clinical decisions as far as looking at that patient and saying, do they really present as a COVID patient? Because as a patient progresses in the infection, that virus, the load tends to move down towards their further down into the respiratory system. So what we can collect pretty early and detect early on in the nasopharyngeal cavity, we can't collect later on in the infection. It tends to be like a false negative at that point. So more of that is really based on the physician's evaluation and is more diagnostic at that point. I think that's all I have for today. We are still sending all of our drive-through specimens to our third-party laboratory and seeing actually less than 2-day turnaround time for those. So we're doing really well. When John says we have 87 samples pending, that's literally from yesterday. So we'll have those back soon. So thank you.
As you heard from John, our drive-through testing numbers actually have gone up, and we've actually, I think, it's plain and simple, it's been the social distancing that we've done a great job of as a state. There remain vulnerabilities, again, until widespread testing and a vaccine is developed. But if you're looking for an opinion on that, it's been because of the social distancing.
The CDC announced making it a requirement for everyone to wear a mask inside of the hospital. So we're wearing them as well. We've taken them off to do this interview, but all of our staff, so you will see people no matter what areas of the hospital they work in, and also for anyone that comes in. You know, we've limited our visitors, but we do make exceptions. But when those individuals need to come in, they will be required to wear a mask as well.
Well, obviously, the big news was at the end of March, and so really we haven't, in terms of shutting things down, we really haven't seen all of the impact yet for April because we haven't closed those books yet. But what we are seeing is about a 30% drop in our daily revenue right now. Now, our expenses haven't dropped 30% for a whole number of reasons, not the least of which is the additional cost of taking care of COVID patients. They've stayed, though, relatively flat, and that's because they haven't gone up. They've stayed flat because we aren't doing those very high-cost surgeries that are many times an inordinate amount of our expenses on a monthly basis. So we already have a team of folks, including physicians, working on the reopening portion of the phase, the pandemic phases that we're going through right now. And so we're looking at some tiered reopenings, and that will be happening again as those permissions come from the government. But we think that if this is just a short time shutdown that we've had on the elective side of things, the financial impact of this is really fairly small in the big scheme of things. We know that we're going to have a lot of pent-up demand in the latter half of the year, and so all in all, we think that we'll do well. On the whole, our financial position, while it may take a short-term hit, on a long-term basis is still very, very good. Well, I would say a couple of things. Number one, as you're aware, we're redeploying staff in a whole number of areas. And that includes things like the walk-up clinics, the drive-through clinic. It includes as well things like grounds crew. We've put some folks on our grounds crew to spruce some things up around here. We have folks at all of our doors where visitors are coming in, taking temperatures. So a whole variety of things that we're doing to redeploy staff. And they're doing a fabulous job. They've been very eager and very willing to come in and keep working. However, while we've been redeploying, that's probably only a little over half of the folks whose departments have been closed, or maybe they've been low volumed. That's the term that we use often. When that happens, of course, some of those folks can't be redeployed. And so we've put a pay stabilization program in place to make sure that those folks are still doing well financially in this interim term. We fully expect that sooner rather than later, we'll be opening things back up. We know that these folks are valuable. We want them to be in a place where they can effectively deal with any stress that they're having on their family and also be ready to go when we're ready to get things opened back up. First of all, we expect a surge to come. We just don't know how quickly it's going to come, how long it's going to last. Actually, what we're not expecting is a surge to last for a very, very, very long time. We're expecting that we'll be opening up sooner rather than later, even though that is still some weeks or maybe a month or two away. We also know that surges might not come once and then be done. They may come in a rolling fashion as different hotspots are found, whether it's in Lincoln or whether it's around the state. So we're planning those scenarios, everything from a 2-month to a 12-month and everything in between, reopening of Bryan. And we're working on that. Again, we're working to make sure that we're very strong and sustainable fiscally and making the good decisions around that, but also making sure that we're valuing our other really, really important asset, which is that of our employees. When we talk about elective surgeries for the directed health measure, what that really means is not surgeries that can be put off forever, but surgeries that can be put off for a short period of time. Some of these might be able to be put off for quite a long period of time, but really elective means really pre-planned. And several of these pre-planned surgeries really do need to be going on maybe a little sooner and not able to wait through the whole surge. So we're looking at those every day. There may be some that we've been able to put off, but others that we're going to be bringing back on sooner. And I think that the governor has given us that flexibility. He's talking with us on a regular basis about how we might open things back up. We had a call yesterday with hospitals all around the state, and we're giving advice to him, and he's asking us some really good questions about how we can do this. And again, I expect that we're going to see at least some level of elective surgeries in a tiered fashion opening up sooner rather than later. So is the medical staff involved? Absolutely yes. Again, we're beginning to coordinate a group of physicians that will talk about both if we open up, when we open up, and how we open up. Because the important part is, even if we were given the go-ahead today, we're still going to want to know a number of things. How can we make sure that the people coming in for those surgeries or those procedures or those tests are still going to be safe for the people performing those procedures and surgeries and tests? How can we make sure that they aren't going to be affecting anybody else? Do we have the proper protective equipment? Do we have the proper blood supply? So there's a lot of decisions and discussions that we're having to say, what needs to be in place for us to do that well? You can only do that with an active medical staff, not just our own employed medical staff, but physicians all around the community are involved in that discussion. Yes, we have. In fact, every one of our organizations, Bryan Medical Center, Crete Area Medical Center, Merrick Medical Center, Bryan Physician Network, Bryan Heart, have all received funds. Actually, they received those one week ago. I think all of them came last Friday. So yes, we've received the first set of funds that were distributed pretty equally around the nation. Now you might note there's a lot of discussion right now about the next set of funds. We don't expect those to be distributed equally around the nation, and we don't expect to receive any of those at this point because we believe that they'll be targeted more at some of the hot spots around the nation.
To give you an example, just from decreasing the elective surgeries, there's a lot of people in those surgical suites or in the prep area or the recovery area. If you look at some of your elective test and outpatient procedures, a lot of the folks from those areas we're putting in different departments throughout the hospital. So anything that you would think would be an elective type of test, procedure, or surgery, those are the types of departments where we're redeploying those staff.